I don't know why PK always asks me to talk about complications in every conference I come to. I don't know what the word is out there. I do safe cases just to be safe. Yeah, we'd like to see his PACS list. So I'm going to talk about dealing with iliac complications, and I think we've kind of touched on all of this in terms of you have to have equipment ready. You have to know what your ins or outs are. What are the kind of precautions you have to take? I'm not going to tell you how amazing Chicago is again today, but yeah. Iliac artery revascularization, we've changed, as Dr. Bianchi just eloquently showed, from surgery to endo first. So with that, we're learning a lot more what we can do with those pelvic arteries. One thing we have to remember that, just like we respect the profunda, we should respect the iliacs, because that pelvic cavity can hold several liters of blood before it self-tamponades. And by the time it self-tamponades, you're probably in the autopsy side of it. So I think it's very important, especially with these heavy calcified patients, especially the ones we have in the Midwest and everywhere else with heavy, just terrible calcium, the smokers. We have to be very cognizant of it. So the cluster moment in most PAD work is when we have a situation where this is kind of the scenario, and you hate to see this, right? That's kind of like oh crap, once you regain consciousness, you have to think about what you're going to do here. And, right away you should be having your balloons ready. Sometimes you have to think about a Reboa or an aortic balloon while you get a balloon just to tamponade it, and then get your covered stents ready. So none of these should be done in anywhere but a hospital setting. I don't know what's happening out there. I don't think this has made its way into the OBL yet. I'd like to know. I don't think that's where this stuff can go, but this is what you don't want to have, right? Here's a patient where this does happen. Right lower extremity progressive claudication, has a smoker, coronary artery disease, and showed a common and external occlusion, which reconstituted just above the common fem. You can see here is going along. It's one of my a friend's case, of course. I never have complications, but you see the chronic occlusion. We're watching them do it. Everything's going well. The recant ipsilaterally was actually not bad. Pre-balloon just to get a stent in, bare metal stent was placed. Now, it's important to do the conscious sedation for these patients if you can do it, and that was mentioned before, because you really want to listen to the patient, listen to your merge screen or whatever you're using for your hemodynamics, and also your nursing should be very on top of things, because the pain starts increasing in this patient, and then the pressure starts slowly decreasing sometimes because it's bleeding and bleeding and bleeding, and the body's been compensating. Finally, it doesn't work anymore. Then the tachycardia sets in for the patient as well as myself, if in those cases. So never do it without covered stent grafts or the right balloons. And then decide on your stenting. You can consider the Reboa, you can consider reversal anticoagulation, but your first step is just get that balloon up. So in that case, get a balloon up, had bare metal stent in that situation. In this case, you see the little bit of extravasation after bare metal stenting. So that's why it was slowly creeping, because it wasn't a rapid bleed like I showed you in that first image. Then you got to get to your covered stents, and then you can salvage the case. Now, you have to monitor the patient, and that's a nice little straightforward situation. And this is hopefully the extent of what you see. I had a companion case I added from my partner the other day, called it faint of heart. So it's an 80-ish-year-old patient, coronary artery disease, had a STEMI, and we have a lot of cardiologists in the room, so I'm sure some of this will come to you guys very easily, but has a PCI for an RCA occlusion, had some stents, and needed a balloon pump. So we get a friendly call at the end saying, patient's got some symptoms on the table, they did some angios, currently has a 6 French sheath in the right and an 8 French in the left. And I don't know what's going on in the heart, but I know this is the heart. I'm not sure what else they did here, but I'm sure you guys saw something exciting here. I don't know. But regardless, this is what they saw on their sheath around on the right side when the patient was having some symptoms. So clearly there's an issue now. So we kind of get involved, and this is the angio. So now not only do we have a problem on one side, we have a problem on two sides. So these are the kind of things you got to worry about. Now, it's not a frank extravasation, but it was dissection. So during the process of treating the heart and getting the balloon pump and all these things, there was unfortunately bilateral injury. So you can see we have up and over sheath, we're kind of doing a pullback to see where exactly the extent of the disease is. So, it depends on what you want to do here, but for me in these situations, when you're trying to deal with it quickly, I think covered stent graft is the right way in the external part of it, if you can land it there, and then I'll tell you what our plan was for the proximal part, once this is done moving here. So covered stent was placed in the external, and then for the proximal, because we wanted to preserve that hypo, we saw that there was some disease right at the common iliac as well. So in that one, we placed a bare metal Zilver non-drug coated stent. Obviously, it's not drug coated, larger size in that side, and we were able to get a nice result there. Now we got to deal with the other side as well. One was not enough. So this side, same thing. We had to decide how to do this. So the sheet that they had was a little too high. So we had to get a second axis on that left side and take out their other sheet. Luckily, we have Fellow Seal, which is a wonderful closure device. And did a covered stent again in the external, and again put a bare metal in the disease near the common, and that's kind of how we decided to treat that case. So in the interest of time, in summary, never do these cases without the right balloons, especially aortic balloons. Listen to the patient. Plan to fail, because if you don't, you're going to fail for sure. And then be friendly with everybody. I think we learn from each other. I think we're doing a lot more in these iliacs in these areas. I think the aggressiveness is great, but the last thing you want is a death on the table from an elective case. And we'll talk about that tomorrow during cocktails. But thank you, everybody.